Welcome to this presentation on performing a head-to-toe physical assessment. My name is Roberta Brothman, and I am a registered nurse clinical consultant from 5-Star Clinical Solutions. Our objectives for this presentation are to be able to identify the difference between a full and a focused assessment, understand elements of a head-to-toe assessment based upon body systems, understand what additional data should be collected, be able to perform a focused assessment or put the picture together, understand how to complete the SBAR tool, improve communication to the physician or nurse practitioner regarding any patient change in condition, and improve assessment skills to reduce returns to acute care. Our head-to-toe assessment. When should we perform a full head-to-toe assessment? This should be done on admission to the facility or readmission to the facility after an interrupted stay. What is a focused assessment, and when should we perform a focused assessment? This should be performed each shift and is guided by the admitting diagnosis. It should also be performed at change in condition and is guided by the patient's chief complaint and focused on finding the underlying cause. Let's begin with the admission assessment. We want to organize our process. Make certain to assess every body system, beginning at the top of the head and working our way down the body. Neuro, respiratory, cardiovascular, gastrointestinal, genitourinary, integumentary or skin and wound, musculoskeletal, looking at function and safety, and finally the 5 senses of hearing, vision, touch, taste, and smell. Let's begin with our initial assessment. We want to observe the patient and their surroundings. A great deal of information is gathered by direct observation of the patient and their reaction to their environment, their gross motor skills, visual acuity, general cognition, unkemptness, appropriate weight, approximate height, interaction with family, friends, speech, etc. Again, much is observed. Beginning with the neuro assessment, we want to assess cognition and cranial nerve function. Is the patient alert and oriented to person, place, time? Are pupils equal and reactive to light and accommodation? We want to assess bilateral strength, smile, closing of the eyes, finger squeeze, push and pull on the feet. Are these bilateral in strength? When the patient is asked to squeeze their eyes shut, does one remain open? When they smile, is there a lopsided smile indicating a possible stroke? Check speech. Is there aphasia? Is it expressive, receptive, or global? We also want to look at the 12 cranial nerves. And here's a little mnemonic for you to remember the names of those cranial nerves. On old Olympus towering top, a Finn and Greek view some hops. It's a little mnemonic to remember those. Let's look now at the respiratory assessment. The respiratory rate and depth should be observed, and look for any complaints of shortness of breath. Pulse ox or PO2 is measured. Note whether it is on room air or if on oxygen, what is the rate? What is the delivery system? Nasal cannula, venti mask, non-rebreather. What is the respiratory rate, rhythm, and depth? Does the patient need to use accessory musculature? Is there presence of a barrel chest indicating a long-term COPD diagnosis? Listen to the lung sounds, both anterior and posterior. Are they clear? Do you hear ralls or crackles? And if you have never heard ralls or crackles, you can take your index finger and your thumb and take some hair and put it next to your ear and just rub it together, and you'll hear a little crackly sound. That's what crackles or ralls sound like. We want to distinguish fluid from atelectasis. How do we do that? If you hear crackles, ask your patient to take a deep breath, a few deep breaths. If the crackles dissipate and they disappear, you'll know that that's most likely atelectasis. I liken this to if you have a balloon and you blow up a balloon and deflate it multiple times, it begins to get sticky on the inside. It's the same way with the alveoli of the lungs. If a patient is not moving around, not taking deep breaths, atelectasis can form, and of course that's a precursor to a possible pneumonia. So if the atelectasis or the crackles dissipate with that deep breath, most likely the patient needs to move. Maybe they need an incentive spirometer. If it does not dissipate with those deep breaths, it is potentially pneumonia, or it could be heart failure, fluid in the lungs. Do you hear rhonchi? Rhonchi are a much more deep sound and indicates that there might be phlegm or in the actual alveoli and in the bronchial tubes. Are there wheezes? Are the wheezes inspiratory, expiratory? These are a much more high-pitched sound. Are there diminished sounds? When you're listening and the patient is actually taking a deep breath, are you not hearing much air exchange? This could indicate a diagnosis of COPD. Look at whether or not the patient has a cough. If they do, is it productive, non-productive? What is the type of sputum? Is it thick? Is it have a different color? Are they able to clear their airway by themselves and maintain their own open airway? What is the respiratory diagnosis upon admission? Do they have a pneumonia, asthma, aspiration, COPD, CHF, CF, cystic fibrosis? Is the patient on any antibiotic therapy already? Let's look at our cardiovascular assessment. We want to assess peripheral pulses for strength. Are they +1, 2, 3? Are they bounding, regular, irregular, regularly irregular, meaning that maybe every second or third beat is skipped? That might be an indication for looking for an EKG. Assess vital signs to include orthostatic BP and heart rate. Have the patient lie down, take BP and heart rate, have them sit up, wait for a few minutes and retake, and then have them stand. Do they become dizzy? Do they drop their blood pressure, increase their heart rate, indicating possible dehydration or even cardiovascular disease? Assess capillary refill. How many seconds does it take after you press on a nail bed to see whether or not the nail bed pinks back up? Assess heart sounds for any obvious rubs, murmurs, or muffled sounds. Assess for peripheral edema, abdominal distension, again the ralls or crackles, jugular venous distension. These are all indices of heart failure. Moving on to the gastrointestinal system. Assess the patient's ability to chew. Do they have teeth? Do they wear dentures? Are they poorly fitting? Are they able to swallow? Can they eat solids, drink liquids? Is the weight within a normal limit? What is ordered on the diet and why? Do they have any food allergies that we should be aware of and make the dietary people aware of? If weight is an issue, we certainly want to get a nutritional diagnosis and referral. When was their last bowel movement? Do they have a history of constipation? We want to next palpate the abdomen. Is it soft, firm, taut? Do they have pain? Do we see a fluid wave? The way to assess for a fluid wave in the abdomen is to place one hand flat on the abdomen and then take your opposite hand and tap the fingers. You will see a fluid wave go across the abdomen. If it is not present, of course, you won't see that. Listen to bowel sounds. Are they hypoactive, hyperactive? Are they present in all four quadrants of the abdomen? Moving on to the GU or genitourinary system. Is there a presence of or a history of a recent Foley catheter? Document the reason for the Foley. Plan to discharge that Foley as soon, or discontinue, that Foley as soon as possible. Does the patient have a history of urinary retention, a neurogenic bladder, BPH in males, or perhaps even a spinal cord injury necessitating the use of that Foley catheter, oftentimes a suprapubic catheter in that case? Is there urinary incontinence? Is it stress-related, overflow-related? Is there a detrusor insufficiency? Poor cognition and recognition of the need to void? What is our care plan in the case of incontinence? Moving on to skin or integumentary, we must look at every part of the patient's skin upon admission and create a wound and skin documentation record for all patients. Measurements are always documented in the following manner: length, then width, then depth of the wound. An RN needs to stage wounds, 1, 2, 3, and 4, unstageable, or deep tissue injury. Please don't forget DTIs, as these are extremely important, and the wound will almost certainly break down. So what's the cause of the wound? Is it pressure? Pressure ulcers are over bony prominences. Is it related to shearing? What can we do to reduce shearing? Is it moisture related? Is it vascular? If it's vascular, is it arterial or venous? Is it neuropathic or diabetic? Is there a skin tear? What is the skin turgor? You can determine this by pinching the skin slightly upward, and it should return to normal within a second. If it does not, it's an indication possibly of dehydration. How about mucous membranes? Again, an indication of dehydration. Is the mouth dry? Is there fragility of the skin? Is there a presence or absence of subcutaneous fat, which we see, of course, in the elderly? Are there moles, scars, wounds, incisions, skin tears? Is the skin dry or flaky? Are there rashes? What do the feet look like? The toenails? And what is the temperature of the skin? Is it warm to the touch, cool to the touch? Does it vary in the feet, the legs? Moving on to musculoskeletal. What is the general appearance of the muscle condition? The tone of the muscles of the lower and the upper body? What is the functional mobility? When determining functional mobility, we need to make certain that we have our patient get up and ambulate if at all possible. We don't want to just simply take the word of someone else. We really need to take the time to ask them to sit up, stand, and try to ambulate safely. What is their safety awareness? Assess their ambulation. Do they use an assistive device? An assistive device may not be just a walker or a cane. Are they using the overbed table, the furniture in the room to be able to make sure that they're steady and able? What's the steadiness of their gait? Do they have the ability to reposition in bed? Let's move on to the 5 senses. Very important. Hearing. Does the patient use hearing aids? Do they have hearing aids that they do not use? Is there a presence of wax in the ears? Their vision. Do they have glasses? Do they fit properly? When's the last time they had their prescription checked? Do they have a history of glaucoma, cataracts, blindness, or even eye injury? Continuing with the 5 senses, taste. Ask the patient about their tasting of food. This is very important when you consider the patient's weight and nutrition. How about their sense of smell? Do you realize that the sense of smell influences greatly our sense of taste? Touch. Recognize that a diagnosis such as Raynaud's can certainly impact the patient's sense of touch. Now let's talk a little bit about the focused assessment. Certainly we can't perform a full head-to-toe assessment on every patient every shift, but we can perform what I call a focused assessment. This is done every shift and also when a new complaint or concern is identified. The focused assessment concentrates on the areas of concern, the admitting diagnosis, the chief complaint, or newly identified problem. We'll talk a little bit more about the focused assessment in a moment. We want to identify the body systems most likely involved in the chief complaint. We want to perform systems assessments to determine any abnormals and check other data such as labs, vital signs, medications that may impact the body system or chief complaint. We want to use the SBAR tool to organize that picture that we're collecting. We want to put the picture together and report concerns to the physician, nurse practitioner with your SBAR observations. Preventing escalation of the problem or chief complaint is critical to the quality of care the patient's well-being, and keeping those returns to acute care as low as possible. I cannot stress this enough. For example, catching a CHF exacerbation early can prevent complications of rehospitalization and poor outcome. So here's a scenario for you. See if you can catch the problem in this scenario. A 73-year-old male patient was admitted 3 days prior with a diagnosis of status post CABG, mitral valve replacement, and a remote history of renal failure. The STNA or CNA notifies you that the patient is complaining of shortness of breath. His pulse ox is 88% on room air. What type of assessment do you perform on this patient? This focused assessment. What data do you want to collect before calling the physician or nurse practitioner? What do you think the problem is, and what do you recommend to the physician or nurse practitioner? What does your SBAR assessment include? I'll give you a moment to just think about those answers to those questions. So let's look now at some solutions. A focused assessment should be performed with an emphasis on both the cardiovascular and respiratory systems. Because the patient's history includes a CABG and a mitral valve replacement with a history of renal failure, it is possible that the patient has complications related to these concerns. Begin the assessment looking for signs and symptoms of fluid overload, either secondary to heart failure or secondary to renal failure, or actually both. Auscultate the lung sounds. If they are wet, you hear crackles or rolls, have the patient take a deep breath. If they clear, then most likely it could be atelectasis, and place on incentive spirometry and ensure that the patient is moving and ambulating per safety guidelines with therapy. Does the patient have increased temp or white blood cell count? If so, could be suspicious for pneumonia, and you might want to request a chest x-ray. Does the patient have a productive cough? If so, what color is the sputum? Again, could potentially be pneumonia. If lung sounds are wet and do not clear with deep breaths, assess for other signs and symptoms of fluid overload. Assess for peripheral edema to include the feet, the legs, the abdomen, and the sacrum. If fluid overload is present, check the medications for a diuretic. Was it decreased or stopped in the hospital or upon readmission? Check weights for trends. Generally, 3 pounds in 1 day or 5 pounds in 1 week of weight gain is an indication of worsening heart failure. Check labs for the BMP, the BNP, which is indicative of heart failure, renal function panel. Is there an indication for fluid overload, CHF, or renal failure? The patient should be placed on oxygen. Let's look at our actions here. Immediately at the lowest rate to achieve a pulse ox of over 90 to 95%. We would like to elevate the head of the bed and place the patient at rest to conserve oxygen demand. Check all other vital signs. Check skin turgor. Check mental status for any change from baseline. Check trends in patient weight, as well as the intake and output if you have that, and fluid balance. Create your SBAR report before calling the physician. Under situation, the patient's complaint of shortness of breath with a PO2 of 88% on room air is the situation. The background, patient was admitted with a diagnosis of status post CABG, mitral valve replacement, and a history of renal failure. In our assessment, the walls are halfway bilaterally posteriorly. The patient has 2+ pitting edema of the bilateral lower extremities and a pulse ox of 88% on room air. This increased to 96% on 3 liters of nasal cannula oxygen. The vital signs were 98.5 oral temp, 72 regular heart rate, 28 respiratory rate with orthopnea, Blood pressure was 130/72 sitting, 134/78 standing, and the weight is up 4 pounds from admission 3 days prior. A review of the medications indicates that Lasix 40 milligrams BID was decreased upon admission to the rehab facility to 20 milligrams PO daily. The labs are within normal limits except the BNP, indicating heart failure, was over 600. So what are your requests and recommendations to the physician? Request a stat chest x-ray to rule out heart failure, a repeat BNP, increase the Lasix to 40 milligrams PO daily to begin, a BMP and a renal panel draw in 24 hours, daily weights, if not already ordered, and report increase of 3 pounds to the physician or NP at once. Clearly, when we call the physician or nurse practitioner with this kind of information, rather than something like the patient is short of breath, the physician is able to make a better decision as to whether the patient can be managed in-house or be sent out to the hospital. Know that you are a difference maker in the lives of those in your care. Your ability to assess your patients, use critical thinking skills, problem solve, and communicate clearly makes you a lifesaver. How incredibly powerful, and what a privilege it is that you possess that ability to save a life. Thank you so much for your time and your attention to this very important assessment piece. If you need to contact me directly, here is my information and my phone number.